Let's now move to understanding the principles of direct chop. The fundamental difference between Phaco 1 or sculpting, the chapter which we have just completed, and chopping is that sculpting is a technique that happens under direct visualization. As opposed to that, when we talk about a direct chop, it is more a kinesthetic procedure wherein we actually rely on the feel of the instruments, because the Phaco tip is now buried into the nucleus and you really have no clear visualization. Let's start with understanding the technique. The principle of chopping remains unchanged. Whether you are doing a stop and chop wherein you have made a groove, divided the nucleus into two halves, but you're still going to use the same technique of chopping to break each heminuclear into two halves. What I will try and demonstrate and elicit and make easy for you all to learn is how do you get started, get going and get proficient in performing the direct chop technique. It is very important for you to understand your particular machine in your OT, and based on the density of the cataract, what is the particular power modulation that you would choose for this particular eye so as to minimize the energy delivery into the eye. So in this particular case, what we are planning to do is the direct chop technique, and the settings are set as follows. The vacuum is set at non-linear of 300 millimeters of mercury. That is, as soon as you go in foot pedal 3, the vacuum remains and is maintained at 300 from the beginning of foot pedal in position 3 all the way down to maximum depression. So also the flow rate, that is the rate at which things happen in the eye, is set at about 28 cc per minute, which means again it is non-linear. That is, at the onset of foot pedal 3, you're giving a flow of 28, which remains all the way 28 from the beginning of foot pedal 3 up to maximum foot pedal depression. The power setting that we have kept for our particular grade of cataract is 35%, which seems to be optimal. But please note that the Phaco power here is being delivered in a linear fashion, which means at the beginning of foot pedal in position 3, it will start at 0, and as we progressively press the foot pedal, it will then move to 35 at the point of maximum foot pedal depression. Furthermore, let's look more closely at the power modulation used in this particular case. We know that we've kept the Phaco power at a maximum preset of 35 in a linear mode, but if you look at the column on the right, the mode that has been chosen for this case is the occlusion micropulse. So what that really means is that till you achieve occlusion, that is, before the tip is completely occluded, the power modulation which will be in play is the pulse mode. Depending on how much ever the foot pedal is depressed, the power at that time is delivered 50% on and 50% off with every pulse. Now, what happens when you get occlusion? Then the occlusion micropulse mode comes into play. So in the occlusion micropulse mode, in this particular case for these settings, the on time is 6 for a count of 40 pulses per second, which comes to 6 into 40, which is 240, thereby giving you a duty cycle of 24%. Now let's understand the principles of direct chop on a model eye. The preliminary steps, that is your incision, your capsular excess and your hydrodissection, remain absolutely the same. Make sure that your Phaco probe, your tip are optimal. You've got adequate exposure of the tip is not damaged in any way, and your second instrument is a chopper which is of the adequate length and sharpness that you desire for that case. So once more we come to the model eye, wherein this we assume is the pupillary edge and the rhexis edge. Now where would you start your chop? It's very important to note that the nucleus is a biconvex disc, and therefore to be able to get to the absolute depth, I would rather prefer that the surgeon start the chop not in the center, because if they started chopping in the center and went down, they would almost reach close to the mid-periphery. However, if they started chopping proximally and went in a downward direction to impale the nucleus, you're likely to get down to the depth of the nucleus in its thickest part in the center before performing the chop, that is the lateral separation with the second instrument. So, to recap, you start your chop here, just beyond the proximal rexus, not in the center, but start chopping here. So you enter into the eye with the bevel down position, use both hands, turn the probe into the bevel up position. Your second instrument, which is a chopper of adequate sharpness and adequate length, is now introduced through the second side port incision, and now you're ready to chop. Let's now understand the foot pedal control for performing the direct chop. Before entering the eye, we move to foot pedal 1, that is the irrigation. Now we've done all the same steps, that is turn the bevel up, get your second instrument in the eye. Then we move to foot pedal 2, which is aspiration, and clear all the cortex which might be blocking our view of the anterior nuclear surface. We move back to foot pedal 1, and now we are ready to perform the direct chop. So the foot pedal moves from 1 to 2 to 3. As soon as we move in foot pedal 3, the probe now impales the nucleus, that is starting just beyond the proximal rexus all the way down to the center to get a good hold of the nucleus. When the probe is adequately buried, the foot pedal now moves to foot pedal 2, which is aspiration, and holds on to the nucleus in foot pedal 2. Once this hold is maintained, the chopper now mechanically separates the nucleus into two halves or the fragment into smaller fragments by lateral separation of both the probe and the second instrument. Once the nucleus is separated, the foot pedal again moves to foot pedal 1. So, the foot pedal movement for direct chop is 3 to bury, 2 to hold, chop, and then the fragments are removed. Let's look at the foot pedal control for fragment removal. So the fragment that you want to emulsify should be opposite your tip, and you are currently in foot pedal 1. So foot pedal 1. Whilst remaining in foot pedal 1, the probe now moves close to the fragment. Now, which part of the fragment are you going to emulsify? You don't hold it too superficially, neither do you hold it too deep. So, whilst remaining in foot pedal 1, the probe now is taken against the fragment somewhere midway down its depth. Now you're ready to emulsify. So, the foot pedal now moves to 2 and then 3. Only when you get to foot pedal 3, you bury into the fragment, just enough to get a hold. Once you've got the hold, move back to foot pedal 2, bring the fragment up in foot pedal 2, go back to foot pedal 3 and emulsify the fragment, and as soon as the fragment leaves the tip, foot pedal moves to 1. So it is 3 to bury, 2 to hold, 2 to bring up, back to 3 to emulsify, and 1. So for fragment removal, it is 3, 2, 3, 1. Currently, the foot pedal is in position 1, probe is in the eye in the bevel up position, your cortex is cleared, your chopper is in the eye in a downward position ready to chop. With the eye always maintained straight such that the iris is parallel to the ceiling to allow for you to see clearly, you start with the direct chop. You move from foot pedal 1, which is your irrigation, to 2, which is your aspiration, still no movement of the tip. But when you go to foot pedal 3, that is the Phaco, now you're ready to perform the direct chop. Your foot pedal is currently in position 1. You move to foot pedal 2, which is aspiration, still no movement of the tip. And then you go to foot pedal 3, which is the onset of Phaco emulsification. So as your foot pedal moves into foot pedal 3, that's when you start chopping the nucleus. So your probe now starts burying as though to go towards the center of the nucleus, starting point being just beyond the proximal rhexis. So foot pedal 3, the phaco starts, and then you go all the way down. It is blind. You bury it till you get a good hold of the nucleus. Now, how do you know you've got a good hold of the nucleus? When you have successfully impaled the nucleus, if you were to just get to the depth that you want, once you've got to the depth, you go back to foot pedal 2 and elevate the probe. As you elevate the probe, you will see that the nucleus also starts to lift up. This upward movement of the nucleus with elevation of the probe suggests that the nucleus is properly impaled. Why do you stop in foot pedal 2? Because once you've got to the depth, you need the phaco energy only to go all the way to impale the nucleus to get a good hold in its depth. Once you get that hold, your foot pedal moves to foot pedal 2. The importance of this is to understand that if you were to remain in foot pedal 3, you would go through and through the nucleus and into the posterior capsule. So once you get to the right depth in 3, foot pedal in 2, impale the nucleus, you lift up the nucleus and confirm fixity into the tissue, and then it is the job of the second instrument to impale into the nucleus just beyond and lateral to it, while maintaining the hold of the nucleus with the phaco probe in foot pedal 2. The second instrument, which is your chopper, is held in a vertical position and impales into the nucleus just beyond and lateral to the tip, and both instruments now are moved apart. Now that we have understood on a model eye the technique of direct chop, the power modulation, the foot pedal control, let's put it all together. So if we were to combine this with the foot pedal control, you're in the eye, foot pedal 1, bevel up, you've gone in foot pedal 2 and cleared all the cortex. You have an absolutely clear visualization of your line of burial. So in foot pedal 1, you remain. You focus on the anterior surface of the nucleus. Your second instrument, which is your chopper, goes into the eye. And now what would be your foot pedal control while performing the chop? Still in 1, then move to foot pedal 2, then move to foot pedal 3. Only and only when you get to foot pedal 3, you start impaling the nucleus. You impale, get to the depth you want in foot pedal 3. Once you believe you've got to the desired depth, your foot pedal now moves to foot pedal 2 just to maintain that hold. And whilst maintaining that hold in foot pedal 2, the chopper now engages the nucleus distal to and lateral to the tip. And while still maintaining the foot pedal 2 itself, both instruments are moved apart to create a mechanical lateral separation and a fracture crack in the nucleus. Once this is done, the nucleus is then turned around. Once the fracture crack is achieved, the foot pedal now goes in foot pedal 1 because we are not holding on to anything yet. This same procedure is repeated. The next heminucleus is brought around, and once more you bury into it in 3. You hold on to the buried tip in 2. Whilst maintaining hold in 2, the two fragments are separated, after which the foot pedal immediately goes into 1. In this manner, the nucleus is downsized into heminuclei and then into individual fragments. Now, for fragment removal, the foot pedal control is as follows. Let's assume this is a pie-shaped fragment. What would be your foot pedal control to remove it? You're still now in foot pedal 1. Always stay in foot pedal 1 when you're doing nothing. Because if you were to go to foot pedal 2, you're going to hold on to things like your pupil, your rhexis edge, and create intraocular damage. To always remain in foot pedal 1. So now you've got a fragment here. What would be your foot pedal movements to removing the fragment? So I go close to the fragment, halfway down its depth. I'm still in foot pedal 1. I go close to the fragment. I now move to foot pedal 2. But I do not bury into the fragment in foot pedal 2. From there, I now move to foot pedal 3. When the phaco starts, I bury and engage into the fragment. Once I've engaged into the fragment, I lift it up in foot pedal 2 to confirm its fixity. I bring it up in foot pedal 2 to the safe zone of the pupil, back to 3 to emulsify it, and as soon as the last bit of the fragment goes in, foot pedal 1. So 3 to bury, 2 to hold, 2 to confirm fixity, 2 to bring up, back to 3 to emulsify, and 1. So 3, 2, 3 and 1.
Now let's get to the surgery itself. This is a case of a grade 2 nucleus sclerosis and we are about to perform a direct chop. Having turned the bevel down, the surgeon now impales into the nucleus, into its middle, goes all the way down and with the second instrument creates the chop, which results in the fracture of the nucleus into 2 heminuclei. The nucleus is then turned to facilitate the chop of the heminucleus, resulting in the nucleus now breaking up into 2 fragments. Now the nucleus is further rotated and this 1/4 of this fragment that seems quite big is chopped into 2 smaller fragments. Turn by turn in a sequential manner, each heminucleus is thereby further subdivided into emulsifiable fragments. This is followed by the emulsification of each individual fragments. As you can see, the fragment to be emulsified is rotated to come to lie in front of the tip. The nucleus impaled midway down its depth and once impaled is brought up and then further emulsified. Once the fragment is emulsified, the next fragment is then brought in front of the tip and in a similar manner emulsified. So the surgeon buries in 3, brings up in 2, back to foot pedal 3 to emulsify and then 1. If there are bits of epinucleus that are flying around, they are aspirated in foot pedal 2. The last fragment is then turned around, impaled, brought up and then subsequently downsized and emulsified until the completion of nuclear emulsification. Let's watch the next case now. This patient has got a slightly harder grade of cataract, like a grade 2 or 3, and the surgeon is about to perform the phaco. With the irrigation on, the surgeon then introduces the phaco probe into the eye, turns the bevel into a bevel up position, and then proceeds with the direct chop. In the phaco mode, the surgeon impales into the nucleus, and after acquiring fixity, the second instrument now is introduced beyond and distal to the tip, and a lateral separation of both instruments results in a chop. After rotating the nucleus, the same procedure of chopping the heminucleus now into smaller fragments is also done. In this manner, the entire nucleus is now subdivided into much smaller emulsifiable fragments. Since this fragment has just come up, it is subsequently emulsified. The surgeon then proceeds after emulsification of the fragment to further subdivide the other half of the heminucleus. So it's rotated into the optimal position. The surgeon is still in position 1, then buries in foot pedal 3, creates the mechanical chop while holding it in foot pedal 2, and then again finally in foot pedal 1. The nucleus is rotated, the surgeon impales in 3, holds in 2, separates and back to 1. Now this fragment has come up while holding it in foot pedal 2 and the surgeon thus further emulsifies it with the chopper lying on its side. Turn by turn now, it's time for fragment emulsification, and you can see how each and every fragment is subsequently downsized and emulsified. So during fragment emulsification, your foot pedal control goes like this. Once the nucleus is rotated, the nucleus is then impaled in foot pedal 3, the nucleus fragment held in foot pedal 2, brought up in 2 and then further emulsified with the foot pedal in foot pedal 3. And upon completion of fragment emulsification, the foot pedal moves to foot pedal 1. In this manner, the nucleus is downsized and nuclear emulsification is carefully and in an extremely controlled manner completed. Let's now look at this grade 3 to 4 hard cataract. The surgeon uses enough viscoelastic and preferably a dispersive one would be nice to protect the endothelium, because despite the power modulation, you're going to require some more energy here. The sharp chopper is introduced first, lying on its side, and then the phaco probe with the best tip they have with a slightly more exposed tip is introduced, and the surgeon proceeds with chopping. So the surgeon now impales deep into the absolute depth to confirm fixity into the nucleus, after which the chopper is introduced both instruments are moved apart and the surgeon takes the time to confirm that the fracture crack goes all the way to including the posterior plate. The nucleus is now rotated and you've got one half of the heminucleus which is now further chopped. So surgeon buries into the nucleus once more, a lot more than you would into a soft cataract, and chops. Again takes his time to confirm that the break in the nucleus is and includes the posterior plate. This fragment itself seems to be quite a big fragment. The surgeon now chooses to rotate again and this fragment is further chopped into a smaller emulsifiable fragment as demonstrated. Clearly you can note that as the cataracts get denser, the fragments tend to be obviously more dense, but they tend to be more fragments because you have got a larger, thicker, bulkier and more dense nucleus. And needless to say, you are going to use some more energy to emulsify these denser fragments. It's very important to protect the endothelium at all times, to further chop, to give rise to much smaller and therefore more easily emulsifiable fragments. Personally, I like to break the nucleus into all its fragments first before emulsifying each fragment turn by turn. And when I do so, I remove the sharp chopper and replace it with either a shorter chopper in case I need to further subdivide, or just a Sinskey hook because it kind of gives me a little more protection to the posterior capsule. With most of the fragments now created, we are now ready to emulsify the fragments individually. In a sequential manner, the surgeon now brings one fragment up at a time in the phaco safe zone of the pupil, downsizes and emulsifies it. So once one fragment is emulsified, the surgeon rotates, and please watch how the fragments are brought up and emulsified. Now if they are a little large like this particular one is, note how the surgeon buries into it, holds it in foot pedal 2, and before bringing it up, after maintaining a hold, breaks that fragment into two smaller fragments which are subsequently brought up turn by turn and emulsified. With this fragment you can see a little bit of the thickened epinuclear sheath that has also come up, which is emulsified in foot pedal 2. Please note that some of these fragments, the edges seem quite sharp, but I do not believe that they actually endanger the posterior capsule. With significantly fewer fragments left to emulsify, the surgeon now replaces the sharp long chopper with a Sinskey hook, thereby affording a lot more safety to the residual fragment emulsification. You can actually reduce your settings, you can reduce your vacuum, and you can reduce your flow if you like to have a slightly more controlled emulsification of the last few fragments. As you can see now, we've come to the emulsification of the last two fragments. And please note how in a very slow, controlled, careful manner, the fragments are downsized and emulsified. This is the last fragment, brought up after burying into it in foot pedal 3, holding it in aspiration. It's brought up and subsequently emulsified. The second instrument always works as a guide that not only prevents the fragments from falling away, but nudges them into and towards the phaco probe. This has been quite clearly demonstrated here. This marks the end of the nuclear emulsification of this rather dense cataract.